Recording in progress.
Oh, well, there we go.
Common pitfalls in ERP for OCD. Test. Katie, do you think waiting a little bit longer? I mean, we're just a minute or two after, wait a few more minutes and then jump in?
I'm not sure, Jenny. What do you think?
I just want to apologize because I thought I started the right meeting and I started my own personal meeting. So I was hanging out wondering what I did wrong. And now I have figured it out. I'm just really late to the party.
Not that late. How's it going, Jenny?
It's good to see you. I didn't get a chance to introduce you. Did you already get introduced or introduce yourself?
Just were figuring out some of the technical stuff and saying hi to Lauren, and looks like we have Tim and Zoom user here too. So welcome everybody.
Awesome. Yeah. And I think we might even have somebody from out of state joining us that I just sent the correct link to, I hope. So that will be fun also. So if you're ready to get started, I'll go ahead and say we're really excited to have you here, Justin.
Thanks, Jenny.
I know you've had a very eventful year like everybody else, but you've had some exciting things happen. So haven't seen as much of you in the last few months, but really want to thank you for being our DFW area ambassador and volunteering to teach us and discuss some of these common pitfalls in ERP. I know you have great experience, BTTI trained, super enthusiastic clinician. I bet your clients just adore you. So I'm looking forward to this. I will say that about CEs, just a reminder for anybody here hoping to get continuing education credits. I will put my email address in the chat. You'll just need to send me an email confirming that that is what you would like. And I will send an evaluation, a short form. And then once I get that back, I will send a certificate to you for this hour. And anybody who's not receiving the OCD Texas newsletter, put your email in the chat for that also. And we'd be thrilled to just keep people on board. And then the last thing, and before I turn it over, is that we are finalizing all of our plans to actually have the 1 million steps for OCD walk really happen, not the virtual walk, a live walk. Always used to be in June. Hopefully we're going to have all 4 of the major cities that we planned on for 2020 participating. And the date we have scheduled is October 23rd. So we will not be walking in the heat of the summer this time. It's very exciting. All right. So I will turn it over to you now.
Thanks, Jenny. All right. So glad to be here. It's great to see some familiar faces and some folks that I don't yet know, but welcome to Common Pitfalls in ERP for OCD. I'm Justin Hughes, as already introduced. Here's some of the basic stuff about me. Passionate advocate. So I'm a clinician, I'm a writer as well, and participate with several organizations. Of course, OCD Texas is an affiliate of the IOCDF. And I'm so grateful to the International OCD Foundation. I really fell in love with treating OCD through their trainings, the first BTTI that I went to. It's just a joy to walk with those who suffer, even though at times part of the process is some of those initial stories that are so painful to hear of suffering. The average sufferer goes 14 to 17 years before getting into treatment. And so the more and more that I work with folks, the more I believe that those who suffer with OCD are some of the sweetest people on the face of this planet. Just love working with those who suffer and helping them break through. So that's what this talk is about here today. So if you would like to download it in its full content, there's some slides that I won't cover here today due to time. This is an abbreviated version. This really is a 90-minute to 120-minute presentation with Q&A. So we are just covering the basics. But you can click on well, you can't click on the link, but you can scan or type that in if you want to download these slides. So, of course, thank you to OCD Texas. Originally, gave an initial version of this with Molly Martinez here in Dallas. So she gets the credit for helping prepare the original version of this. And so we're just continuing to pass the word and spread the message. All right, learning objectives, just real high level. We're going to do a super fast overview on OCD. This is not a primer on OCD. If you don't know what OCD is or what ERP, CBT are, that's okay. You'll maybe learn some stuff, but you'll probably want to go for a primer, have a link for a great video for that if you'd like. We're going to identify research-based roadblocks to effective exposure and response prevention, identify some solutions, and then going to use some Q&A. I'm going to tell you how to do that here in a second. My fancy disclaimers, it's not therapy. We're not just saying that as a CYA policy for legal purposes. Truly, having a treatment provider guiding treatment is so key. There are so many personalized aspects that are so important. So this really is education. There's some mature content in here. I don't have any financial conflicts of interest, not paid for this, not paid for my role. And then last of all, with Q&A, just use the chat feature. So you can chat throughout. Katie is going to try to notice a couple of things and pull out some chat potentially during the talk, but then I'll save some dedicated time towards the end. And also we have trivia, so use the chat for that too. All right, so let's go ahead and review those basics. So OCD, it's a disorder of 3 parts. There are intrusive, unwanted thoughts, images, urges, impulses that are experienced. So notice unwanted, intrusive. They're persistent, they're disturbing. So the second part is that there tend to be, well, those of us in the OCD expert community say that there's always compulsions. We'll talk about this along the way. The DSM that we use for diagnosing lets us say or compulsions, but they're always there. And those are those ritualistic responses that the person feels obligated to do because of that initial distress, the obsession. And then disorder is caused. It's some people may have subclinical traits. There's been studies on those who have subclinical symptoms. But if it doesn't reach a certain threshold and you're not suffering to a certain extent, it might not actually be OCD in its proper sense. ERP is the gold standard treatment. It's called exposure and response prevention. It's a subset of what we call cognitive behavioral therapy. And the most research has been thrown at it, and it's found to be the most effective in the research, even over medication, which SRIs, the next bullet point, those are serotonin reuptake inhibitors, the go-to medications. All of them are actually SSRIs, which you might be more familiar with, except one, which is clomipramine. So that's why we see SRIs. So both ERP and the medication, either or both, are those gold standard treatments in OCD. And it's so key that we say that because there's still all sorts of stuff that's being done and practiced, and sometimes by well-intending providers. And one of my passions and passions of many of the providers who are on here today is to get the word out, to not just use talk therapy, to not use supportive psychotherapy, to not use other interventions necessarily that can be good for other things, but not evidence-based, at least at this point for OCD, like EMDR or psychoanalysis, so on and so forth. Nothing against them. They have their place, they treat things, but when we're dealing with OCD, this is the foundation of what we're working with. But ultimately, thought it was my next slide, we know that ERP is actually really hard. I'm going to talk about that here in a second. It's challenging. And so sometimes we have to use what are known as second line treatments or third line treatments. But before we give up on the gold standard treatment, we're going to dig into many of the ways why it can fall apart or not work or be successful for various folks. So if you need that full intro, you can download the PDF, click on that. It's 90 minutes presentation on that. Okay, so trivia. Use the chat, y'all. I'll wait a second, but we'll move pretty quickly. Any guesses towards the average amount of symptom reduction after a trial in the research. So 90 minutes of an exposure and response prevention session, it's usually 16 to 20 sessions. How much symptom reduction would you guess happens after one trial of ERP? $60 to $70, we've got a C. Okay, well, because that is actually the right answer, great, let's move on. 60 to 70%. That deserves Keanu Reeves. What? So I presented this statistic to one of the local clinics that is attached to a psychiatric hospital. And I was talking to a PA who works for one of the main psychiatrists. She was shocked by this. She didn't know this. 60 to 70%. Now, these aren't guarantees. This isn't snake oil sales. For those of you here in Texas, snake oil salesman, you know, this product, it's a bait and switch. It doesn't really work in a certain way. It's hard, it's difficult. This is not everybody. You don't have to feel bad if you don't get there within 16 to 20 sessions. We need to know that when we stick with it, it can be really, really effective. But ERP is hard. We know that the rates by which people turn down ERP or walk away from it are really high. I mean, some of the estimates are up to 45% of people don't stick with ERP. It requires planning, it requires adjustment, and it doesn't always work as expected. So let's get into the pitfalls and solutions. Here's a broad overview categorized in 3 categories: fear-related issues, compulsive behaviors and rituals, and treatment planning problems. Let's go. Fear-related. Okay, so though we have a gold standard treatment, exposure is massively underutilized, especially in treating children. So one of the aspects of this is that therapists themselves often struggle. You got to admit it, it's hard. Sometimes it is breaking my heart to see the distress that's caused already by the ravages of OCD. And then to push on a person in therapy, challenge them, not physically push, but to challenge them can be really hard. I've had to do a lot of work on myself and a lot of personal growth to learn, first of all, when to push, when not to, but simultaneously to deal with my own concerns or fears. And so therapists can be afraid of it. It's the practicability in outpatients, a setting like this that I'm in right now, for some can be a little tricky. And especially in a clinic setting that's just a standard clinic, not oriented towards OCD and anxiety and exposure therapy, the supplies that you need to have on hand or that you're willing to go get, some people wonder if they can even do that. If you're in a clinic that doesn't understand how OCD is treated, they're not going to look too kindly on you bringing your knife set into the conference room one day. And so if therapists have all these barriers into doing what they need to do for an exposure, it's going to, one, either block it or maybe slow down that process. Therapist distress, also negative perspective. So there's this research study, I think it was Sweden, and actual quotes from clinicians were the following: that exposure therapy is insensitive, rigid, ineffective, iatrogenic, which means causing harm. It's not real world, unethical. Oh my goodness. These are clinicians. So one of the solutions to this pitfall is that we get the word out. And you might think, well, Justin, I'm not a clinician. Like, what do you expect me to do? Well, it's actually been those who suffer with OCD that I think have been the greatest advocates for good treatment. It has been the sufferers of OCD who have persevered in staying assertive and showing up and saying at times to doctors and clinicians, this isn't working. I need something different. This doesn't click for me. And so one of the things that we can do on either side as clinicians or sufferers, one is to do our due diligence and reasonable research, ask good questions. But sometimes it might even be when you come across that person that is talking trash about OCD, using OCD as an adjective, like, oh, that person's so OCD. Clinicians will use these words too. Hey, have you ever heard of the IOCD app? So we need to educate, we need to get out there, have some good conversations. But if you're a sufferer here today, whether you have a specialist or not, asking those good questions, asserting for good treatments, and then going to places like the International OCD Foundation, like how to find a therapist. These are great ways to locate a therapist who's going to know their stuff. All right, so I mentioned this subtly a moment ago. Feel free to switch over to the chat. What population in the research is undertreated a majority of the time when exposure is indicated? So people with OCD, exposure is used for other disorders. Those experiencing poverty, children, or Texans? Oh yeah, see, all right, y'all are great. I wish I had the ability right now. Typically when I do these, I've got like a Starbucks gift card or whatever else. So anyway, I just know I'd love to hand you one of those things here, but nice, way to go, Lauren. Okay, children. These little kids, oh man. So actually, before going on to the next one, I get it. When you think of using exposure therapy with children, what does that seem? What does that conjure up in your thoughts? But exposure is, when it's indicated, it's the most ethical thing to do. It's not putting a child in a situation they shouldn't be in. It's actually helping that child be in a situation that otherwise it's healthy for them. It's going to help them to thrive. And so if that child begins to avoid situations or to count ritualistically or to arrange things in the room a certain way, the most gracious thing that we can do is not let OCD take over for children, but rather to help them do exposures, help them to not give in to the compulsion. So one of the major pitfalls as well, jumping on to one of the next ones, is not understanding and addressing the core fear. So obsessions and compulsions often change. If you know anything about OCD, it's like a game of whack-a-mole. One thing's down, another thing pops up. There's oftentimes many different themes. And so if we don't understand what the core is, we're just going to be running around trying to do all sorts of different things. It's going to be some new contamination that we're triggered by, or pandemic happens. And so all of a sudden that contamination concern for HIV or AIDS or whatever it is, just general germs or getting sick, is going to switch to something else potentially in much more of the unacceptable thoughts realm. It's very, very common to have all sorts of different subtypes and themes of what if I wanted to hurt my kids? And then that switches over to relationship-oriented obsessions. Am I with the right person? What if they cheat on me? Have they cheated on me? Things like that. And so knowing the core fear gets us more to the center of that, which OCD is OCD. The obsession, the compulsion is what we address in treatment, because initially we can't control that much, how much those thoughts are coming up. Actually, we can't control our thoughts in the just the initial experience of them at all. It's a fool's errand. Thoughts don't work that way. Potato, banana. I said it, you're thinking it. At some point, we can't necessarily control a certain amount of the thoughts that are coming in, but it's working with the compulsive process. So if we understand, what is the core for me? Oh, that, you know what? I'm going to contaminate someone else and I'll be responsible. Okay. If that's a core, then most obsessions are going to probably center around that. Maybe there's a couple or a few core themes. It keeps us running around less and starting to address the core more. A technique that we use is called the downward spiral technique. So let's say just classic checking, one of the most common compulsions, and let's say it's harm-related fears, the stove, if I don't check it, I'm going to cause a fire. Well, we can ask us, so what? And keep going. until we basically get to the bottom. It's not psychoanalytic. We don't have to figure out something we don't know or build some insight that we don't have yet. It's a quick process of saying, okay, what about that is scary? So, well, my apartment might catch on fire. Well, most people, that's not their core fear. Okay, so people are going to get hurt. Okay. And what about that is scary? Well, I would be irresponsible. All right, we're getting closer there. And what about responsibility? Well, I'm just a bad person, terrible person. You know what? My life is going to be ruined. I'm going to be taken to jail. They're going to find out that I tried to do it. Maybe from a spiritual standpoint, it's like, I'm a terrible person. There's no hope, no redemption. I'm going to go to hell. The core fear can be, even though there might not be that many different core fears, some people argue that there's maybe only 4. When it comes down to it, it makes a difference in how we point treatments, because if it's responsibility versus, for example, immediate safety, then the exercises that we design are going to be towards that responsibility, because it's the bigger thing that we need to address. So moving along, another pitfall is clients' fear of distress. Distress is distress. It's okay. Like, no one really wants to be distressed. I get it. But life involves stress. And to run from it creates this house of cards. The more that we do that, it's actually the avoidance and the compulsions that block us from facing the fear that make it worse over time. So a fine long-term goal, sure, is to reduce anxiety. I think almost everybody, when I say, what are your goals for treatment? It's a rare day that a person would say, not actually say, I want to feel less anxious or whatever, but in the moments when we're trying to make fear go away, it's almost always just another compulsion. So this is where the OCD specialists and experts are giving attention and giving mind towards what are we doing with distress? For example, deep breathing during exposure sometimes is contraindicated in the treatment of OCD. Now, I will use deep breathing and sometimes with clients at various points in the process with OCD, especially if they have panic disorder. That's a slightly different domain. We're going to get to that a little bit later with the detours. But in the moment, if that's just one more trick to keep themselves from experiencing distress and fear, what's actually happening is they're not getting the full opportunity to learn, was I able to face that? Because there's always that in the back of their mind that they haven't really faced it. And this is true in all of human development. For example, if I never drive myself to work, or I only drive myself to work with a family member present, even if I have that technical ability, I'm not going to really know it. I'm not really going to experientially learn, can I drive to work on my own? I have to do it. And that's what exposure is about. Now, in the intro to exposure talk that I give, and lots of resources talk about the basics, just so you know, exposure has to be sustainable. It has to be personalized. Doing exposure well is way better, way easier than a lifestyle of living with OCD. And so a lot of what we do in addressing that fear of distress, those hard to swallow pills of exposure and response prevention, would be education. Education on how do we change as people? How have we changed before? How have we grown? What times in our life did we experience fear, but we overcame it and it was a good thing, or distress because something was new, or we tried something different, or fear was attached with it and we grew? Well, inhibitory learning, fear habituation, those are fancy terms to reflect the models of how we understand change in OCD. It can really help clients to know, oh, wait, how does change occur? But it's not just an OCD thing, this is a life thing. If we know that, first of all, it's going to be a little easier to swallow as opposed to, oh, well, I just have to do this because I was cursed with this disorder or whatever. No, this is a life thing. And one of the cool things that I see in many clients is that when they take this all the way and they're in full recovery, that they can take it further. And the average person that never had to learn that in the first place isn't thinking of it as actively. If you're thinking about these things actively, they can really spell success in life in different ways. It looks different from person to person. Also, teaching skills to sit with distress, not to avoid. Some of it in the psychoeducation is to consider when in life did you experience something stressful and beautiful at the same time? When was something really hard but wonderful? And I'd like you to even just take a moment to just ponder that right now. What's one thing? I can think of a few just coming into my mind. Think starting a private practice, public speaking, having a child, going to school, college, an exam, at one time tying my shoes, things that felt distressing at one point. In the business world, they talk about the leading edge of success. It's oftentimes where you're still reasonably safe. You're coming up to the edge, but you look and looks like a cliff, looks like it's scary. So we have to teach clients skills to tolerate distress, not to ignore it, not to run from it. You're not going to do it all in one day, but sequentially, consistently, over time, micro steps, doing a little acceptance, doing a little commitment, doing a little distress tolerance. We maintain fear when we avoid it. So if I can't do it for a full hour, let me sit with it for 5 minutes and then 10 minutes. And then maybe I have a bad day and it's back to 5 minutes, but I'm going to hold the line with 5 and then it's 15. So we learn to tolerate distress. I can't underemphasize this today, how key this is. Here's some other slides you can look at separately. Actually, I thought I had a different slide. This one's an old meme. Bad luck, Brian. Has a hard time in life. Tries acceptance, can't accept it. We have to personalize these things for us. A lot of people hate the idea of acceptance. It feels fake. Okay, well, we might have to look at it a little bit differently. How can I live in reality, right? So it's not just like, oh, well, I'm doing terrible right now. Thanks for asking. Am I supposed to accept that? No, what we mean by acceptance is accepting reality as it is, life on life's terms. We have to teach these skills. And if we don't, there's a lot of room for the OCD to still grow. Okay, super nerd trivia. I'm a super nerd. I don't mean that in any offensive way. It's just the deep dive. If you're one of those folks that knows this, I'm going to be pretty impressed. Why do some people write EXRP and others write ERP? Looks cooler to have an X. They're interchangeable. EXRP is for any situation. ERP is for OCD, or it was a typo. I'll jump into this one really quick. So it's actually interchangeable. So originally ERP was developed by the behaviorist Vic Meyer, late 50s, early 60s. Advances led to shifting it with more of a CBT model. So EXRP, but then it changed back to ERP. It's really interchangeable. So sorry if that's too nerdy. All right, so second category of pitfalls and solutions, compulsive behaviors and rituals. So as I commonly say to clients, to simplify it, treatment of OCD is complex, but there's one thing that we're hopefully always targeting, which is to decrease and ultimately eliminate compulsions. So if compulsions or rituals are thriving in any way, well, the disorder is going to be maintained. So you've got to get rid of them. One of the pitfalls, mental compulsions. It might be undetectable. This is where the more we work with it, the more we pay attention to these things, the more we notice it. Been doing this for a little while, and it's still hard for me to know sometimes. And this is where building that rapport and trust and helping clients with their own insight is really huge, because I'm not going to be able to catch everything. I'm not inside a person's head. I'm not a mind reader, even though I'm a clinician. So we need to catch those mental compulsions. Compulsions decrease distress through reassurance or avoidance. Mental compulsions really do the same thing. So if I'm just in my head, if the physical compulsion is searching on Google for that sickness or symptom, or whether the pandemic is going to kill me because of the scratchy throat that I have right now, whatever else. Well, if that's more of the situational, the mental ritual might be running through those results in my mind, or it might be saying ritualistic prayer or any number of things. Here's examples here at the bottom. Mental rituals are tricky and compulsions are sneaky. Schitt's Creek, good one. All right, so we've got to attack all compulsions ideally for, really it's to address all compulsions. There's no perfection in treatment. If you see midway down the screen there, ERP doesn't have to be perfect, which is good news because I'm not perfect, nor are my clients. But we have to holistically address all the significant things that are maintaining OCD. We're going to talk about that a little bit later with relapse prevention, that if we don't, we're much more likely to relapse. So we as clinicians have to be sensitive to clients and guide them. By the way, some of this language is written towards clinicians, so it's for both the clinician and the sufferer. So I can't force a client to see it my way, even if I strongly believe that something is a mental ritual or a compulsion. But we're going to work together to spot those things. And you know what? Clients teach me stuff all the time. So assert for your treatment. Treatment gets better when both sides are firing on all cylinders, when they're speaking openly, honestly with each other. Some ideas, solutions with mental compulsions, context variability. So for example, if I get really good at getting a trigger, let's say POCD, pedophile OCD. Oh my goodness, I felt weird around that child. I must be a pedophile. Why do I feel weird or like I'm some sort of a weirdo when I pass kids? Well, so with context variability, if a person in their exposures are learning to face this unfounded fear, because when it's OCD and we look at the assessment, when we talk about pedophile OCD, we're talking about the person who doesn't have a history of these things. It's the fear of acting on something or feeling strange, or what does this mean? And so context variability would be, okay, you know what? I stop avoiding shows and movies that have kids, but I don't just do that at home. I don't avoid movies that I go out and see. I stop avoiding walking at the park, for example, just in case a kid is there. What if I see them and what if I feel something weird? Context variability is doing basically the same thing, facing that fear, but in different contexts. And it helps with learning. A child who's learning the ABCs, well, to be able to run through the ABCs well, you're going to want to be able to obviously do it with one person like a teacher, but you're going to have to do it at home, at school, on the playground, any number of places. That's the context variability. So when we have mental compulsions, we have to, first of all, catch what it is. So with pedophile OCD, mental compulsions can range from that reassurance seeking through in review, mental review of what did I feel? Why did I feel that? What did that look like? So learning to actually just tolerate that distress. Okay. It might be some scripting, which is imaginal exposure, writing it down on paper. I walked past the park and I felt weird walking by those kids, and sitting with that, not actually ruminating, not mental checking, etc. And then I'm going to do that script at home, and then I'm going to do that script at work, and I'm going to do that script the imaginal exposure. Maybe when I'm close to kids, nearby to kids, that's context variability. Maybe competing responses. So that is a essential part of what's called HRT, habit reversal therapy, which is a subset of the treatment of BFRBs, body focused repetitive behaviors like trichotillomania excoriation. We have to be careful with that one because sometimes it can be compulsive, but sometimes it's helpful if we do something that kind of blocks us, especially with mental rituals, because mental rituals feel so tasty at times. It almost feels like it's weird. It's not exactly pleasurable, but it feels like it's doing something in the moment. So in generalized anxiety disorder, we talk about positive beliefs about worry and compulsions. I've got a blog post coming out about this, the positive beliefs about compulsions, what it does for us. It can pull us in. We may have these positive beliefs like, I got to think about it. I got to figure it out because I'm going to feel better if I do that. Part of the OCD cycle. And so if you're at home a lot by yourself, I mean, a competing response might be not just chilling out completely by yourself. It's with mental rituals, it's trickier. You can't do something physically, but you might pick up the phone and call someone. It's not impossible to ritualize, but it is a competing response to have an active conversation with someone. Back to the side of avoidance, we also monitor at a high level. So the expert treatment of OCD, we monitor to make sure that the person's not using that for avoidance. They're using it to face something and to live life. They're not escaping with a phone call or a competing response. They're using that in the moment as a stepping stone to get further into facing their fears. I talked about imaginal exposure already. I'll keep cracking. There's more of these. Major pitfall, providing reassurance. Reassurance in general, day-to-day, maybe it's fine for the average person, but we define it differently in OCD. So it's persistent reassurance seeking. So sure, I want reassurance at times from friends and family that they still love me. That's okay over many, many years to desire to hear, I love you. And in healthy relationships, hopefully you don't really have to ask for that. But it's sure nice to hear it. And sometimes even just communicating more overtly, that's part of relational science of healthy relationships, being able to communicate those needs and wants. Hey babe, I could really use some encouragement today on something. That is different than what we're talking about in OCD. In OCD, it's specifically connecting to that domain of the obsession or compulsion. And so what we want to do with this is we have to call it out as compulsive. This is a doubting disease. And so providing reassurance actually reinforces the problem because it reinforces that you have to have that to be okay versus you never learn whether you could have been okay in a situation or with a trigger without that reassurance. Does your obsessional content mean that ... For those of you who remember The Rock back in the WWF days, it doesn't matter what the obsession says. Okay, so all rituals, compulsions, including reassurance, must be terminated. And that is a tricky pill to swallow, especially for family. And let me be clear, if you're a family of a person who suffers here today, it's not quite the same as enabling with alcoholism. It can be, but if you know your family member is an alcoholic and you know that they had a hard week and bring home a 12-pack of beer for them, that's enabling. It's just, there's a lot of dynamics and that can be hard for that person too, but it's more black and white with that. Reassurance is, it still doesn't help, but it's not so black and white. It's more nuanced in different situations. So sometimes a person does need encouragement, and oftentimes that person might need to be invited into therapy as well, or have their own therapist to figure that out. How do I hierarchically not just pull out the rug from my loved one, but if they keep on saying, hey, do you think I'm a pedophile? Hey, do you think I could kill somebody? Is there something I don't remember in my past? Was I abused in my past? Did I harm somebody? Did I check the locks? So as a family member or loved one, you can help so much. Most of the time I'm recommending to my clients, if they have a good, safe, supportive family member, bring in a family member, bring in a family member. Let's talk about this so that we get the whole team approach to not provide reassurance. Great resource from St. Louis Behavioral Medicine Institute, differentiating between information seeking, reassurance seeking, on my site. All right, so another pitfall, distraction. I was talking about that a little bit already. And by the way, too, feel free, if anybody has questions, feel free to drop it in the chat. Again, I'll save a little bit of time here in actually about 8 to 10 minutes for some questions at the end. But if there's anything particularly pertinent to something we've covered or we're covering actively, feel free. All right, so yes, distraction during exposure may limit fear disconfirmation. So what we're wanting to do is take the treatment as far as we need to go. And what clinically you're trying to maximize fear disconfirmation. Let me break that down. You're trying to learn and grow in a way where that fear that you feel and maybe think is disconfirmed by both thinking and behaving about that in a different way. CBT, cognitive behavioral therapy. Distraction prevents us from fully learning. Distraction keeps us from learning, can we truly face this? Let's be honest, it's going to happen. You'll do it if you suffer with OCD. But I quickly want to start to shift clients as soon as possible back to that mindset of, oh, tolerating distress. And then, well, what about times when I can't tolerate distress? Well, then we focus on your values. The fact that, yeah, well, what would you be doing otherwise if you weren't suffering in this moment? Making dinner, working my job, etc. Great. Okay, so it's not distraction to then work on the mindfulness of your work task or being with your kids or playing a sport or exercising or whatever else. It might seem like this is just splitting hairs. It is absolutely not, especially when we get into the details of it. Distractions during exposures, one of the major pitfalls that keeps us from being successful.
Justin, my name is Amy. I have a quick question.
Okay, yeah. Hey, Amy.
When you're working with kids with OCD, I think this is like a fine line because you're trying to teach them and engage them in something maybe behavioral, but doesn't distract them from the fear. Do you find like the initial session, whether with adult or kids, like you're kind of trying something? Sometimes I find that I did a distraction, but that wasn't my intention, but that's where it led to. Could you just speak to that for a couple of minutes?
Yeah, well, in the sense you're asking, even if it wasn't the intention, it kind of leads to a place of distraction and what.
Yeah, so it's like, hey, touch this folder that's contaminated 10 minutes, and then like, let's not go wash. Well, then it's like, can we play a game to engage in something? But it's like, did I move that kid slowly over into a distraction so they're not tolerating that distress, or I'm increasing that amount of time that they didn't have to go wash?
That's a great question. Well, in definitely not being the kids expert, let me say that I've done the pediatric BTI and I typically only go down to 11 or 12. What my understanding is, though, with the development of kids, part of what's different is even just the ownership of treatment. It looks different. So by and large, it is much more behavioral, especially the smaller the child. You start working with a 2-year-old, 3-year-old, it has to be just pretty much pure behavioral. But with that, with distraction, executive functioning, prefrontal cortex obviously hasn't developed much. Basically, they're walking around without a prefrontal cortex as a child. And so that's okay. When they get to the spot that they are actually thinking about things, it's one of those things we're going to want to do that more. But for a child, that doesn't have to be active avoidance. That's what they're going to be doing anyway in life. They're going to be bouncing from one thing to the next and thinking about different things. And so that's where it's just going to the behavioral, validating that. But last point with that too is hallmark of CBT too is the review. in that inhibitory learning model. For those of you that saw that, if you want to learn on that more, it's really fascinating, and you can just be intellectual with it, but it's also really practical. That if I have learning that this is bad, I can't do this, I must do this. Inhibitory learning is this model of how do we inhibit that prior learning? Well, one of the ways that we do that is not only do something different, but to review what we're doing that's different. And that's great with kids. The next session, be like, so how did that go? Don't let that exercise disappear from their minds. Bring it back up. Hey, how'd that go touching that folder? How are you doing? How are you feeling today? And that can be really powerful. So not the kid's expert, but those are the top 2 things that come to mind.
Thank you.
Yeah, you're welcome.
Justin,
Yeah.
I also have a question about the distraction piece.
Yeah.
If we're working with clients who have primarily like very somatic focused obsessions
Yes.
and
Yes.
really life inhibited because of sort of the avoidance, not wanting to have those somatic sensations. Like once we've really kind of like primed and set the stage for the exposure, and we're in the exposure, is it considered distraction or more of the inhibitory learning when we are like assisting the client in attending to other parts of the context of the exposure? Like we're outside and like, oh, I mean, do you check out that bird? Like it's blue, and like, what do you smell right now? And then like every once in a while, like checking back in on, like, would that be considered, or is that more in the creating new life experience? Like, you know what I'm saying?
These are great questions. Amy and Katie both. I'm really impressed by this. And Katie, that's extraordinarily insightful, and knowing that you're on the earlier side of your career as well. I wasn't really grappling with that very well until probably just a few years ago. So I'm just very impressed that you're thinking about that. So the model that we have, and just as a reminder, let's go with the best model we have, but also let's keep thinking these things through, right? I welcome the day that ERP is displaced by something that's more effective, but there's nothing that's more effective right now. And so the model of how we understand it to work is that compulsions maintain the disorder, keep people stuck, keep people paying attention to the content of the doubting disease rather than living life. And what's difficult though is the person feels the intensity of if those things were real. And so with somatic concerns, somatic OCD, people begin to, of course, pay attention, become hypervigilant of heart rate, breathing, various bodily processes, usually really automatic processes. And I think one of the reasons that these slides are a little bit scary is that it's like, what? Are you saying I should spend more time? No, because we always do what's called a functional assessment. We functionally assess what is this behavior or mental process doing in this situation. And so for harm OCD, when a person's avoiding knives, that avoidance of the knives is functioning as a compulsion. But for the person in somatic OCD who is hypervigilant on that focus and spending more time with that specific thing, the function of sticking with it is actually the compulsion of reviewing and checking. And so in somatic OCD, the key is to be able to shift the attention, the focus, the mental processes and behaviors in a way that's more in accord with how does a person live who isn't hypervigilant or focused, which means the birds. I love looking at birds. And that's just happened in the past year because my wife and another family member had started to get into birds more. And I'm like, oh, like I just kind of assume like I'm in a big city of Dallas, there's no birds. There are birds. And so it's a lot of that mindfulness. And so the separation is all the more important to be able to say distraction keeps us stuck. We're not trying to split hairs or be perfectionistic, but just ask, what is the function of this? Am I trying to escape that obsession, or am I trying to face it? And so if you're looking at the birds and you really want to be checking your heart rate or breathing, then congratulations, you are a beast and you've stepped into facing some tough exposures. So hopefully that decently answers that, or gets you started at least. It's a complex thing, a lot of learning behind that.
Yeah, no, thanks, Justin. I appreciate the reminder too on just thinking about the functional analysis of it all. Yeah.
Sure, yeah. And we got a question too, looks like privately, so I won't say your name. Can't the insertion of various coping skills, including distraction, be an intermediate step in exposures? Yeah, so before I did the advanced BTTI and talked to Lisa Quinn outside of Boston, I asked that question, and I was so annoyed. I was not getting this question answered by anybody, and I was bringing it up, and I was persistent. And I'm like, but Lisa, like, wait, what are we supposed to do? And the rest of the time, like, we can't just be doing exposures all the time. And that whole weekend was another significant turning point for me. But her response was powerful. Something along, and I don't want to, if I say this wrong, I'm sorry, Dr. Coyne. But what I had picked up from that was we set people up for failure if we teach them in any way or express in any way that they can't handle fear. And so right off the bat, just getting rid of that language of distraction can be useful. And looking at it differently as I'm going to focus on what has meaning, and she approaches it, she utilizes ACT, acceptance and commitment therapy, quite a bit. I do some, she's much more. But what about my values? What do I want to be about? The mindfulness, the focus of that is much more neutral. Distraction is a defensive stance, and that's what we're trying to change. Is it going to happen? Yes. And also the intermediate steps, just like with reassurance, I don't just pull the rug out of clients' feet and with family members. So yeah, the intermediary steps, it's not the worst thing in the world to be like, okay, you know what, like maybe I'm just going to have to go distract. But as soon as we can, let's change that to, well, instead of just seeing it as distraction, can you say, well, I'm going to sit with this exposure for 20 minutes and then I'm going to watch TV, because that's what I like to do anyway after I do something really challenging. A little bit different. So hope that helps. I know it's chat, so it makes it a little tricky to know some of the nuances, but thanks for the question. Okay, so I see I have 5 minutes. I'm going to do this. I'm going to do a quick summary of the last slides. And towards the very end, I'll put a few resources that are out there. Also, I just scheduled, I'm going to do a full version of this live stream, which is an hour and a half plus with full Q&A. So this is the abbreviated version. As you can tell, there's 15 different pitfalls and solutions. So it's a lot to cover, but hopefully I've covered some good ground. So real quick, not distracting during exposures. If you download the slides, you can see all of this. The number one reason treatment fails is because of non-adherence. Practice is critical. Homework in CBT terms, some people hate the idea of homework. I'm out of school, I don't want to think of homework. Well, think of it as life and facing life on life's terms. And what do you want? Do you want freedom? Do you not want to be stuck? Do you want to be able to follow through on a commitment, etc.? That's the ACT side of things that really can help couch these things. So the adherence to treatment is key, but all of the exposure therapists I know, despite the fears that people have, are not these taskmasters. Like look at my office, y'all. Does it look like a dungeon? Like, I hope it's fairly warm and inviting. And I hope I don't seem like a terribly mean person or intensive person. One of the reasons that treatment seems really scary a lot of times is that one of two things: people just don't try it in the first place. But second of all, it's not personalized well. It's too unrealistic. The therapist or the client's coming in hot. They're coming in with the level 10s. When we need to be starting with, on a 0 to 10 hierarchy, maybe a 3, 4, maybe if you're really bought into the process and know what you're doing, start with the 5, but I'm not going to go much higher than that for your first exposure. So when you go home, sometimes that exposure has to be a little bit easier than it was in the office, because it's typically going to be harder when you practice it on your own. Practice is critical. So we got to think through that with clients as well. Never give up, Winston Churchill said. Another pitfall: not going far enough. We have to get rid of all rituals and avoidance, not perfectly, but they all have to be addressed. Terminate the compulsions. So if we don't go far enough, we're going to let, like cancer, the infection spread. So going far enough sometimes involves that deep dive in what is meaningful to a person, the buy-in, their values, what helps them go from the level 5 to level 6. Sometimes it can make people sweat to think of that next small step. Or just a different exposure. Sometimes it's an easier exposure, but it's just different. So what helps with that? Lots of things that we're running out of time to cover. I already talked quite a bit about working with significant others and family. That's a major pitfall. So the solution is to work with them. I have a free guide that I put together you can download. The wrong form of exposure: in vivo is the situational exposure. Imaginal is in our thoughts. Interoceptive is producing symptoms that are uncomfortable, and then virtual reality is kind of a cross between all of those. If you are, I love this little meme, in vivo when you need imaginal, these aren't the exposures you're looking for. So for example, if you have pedophile OCD themes, well, you're going to have some in vivo exposures, maybe going to the park, not avoiding being around children. Sometimes you need both. And at some point, though, if you are spending all of your time doing just behavioral strategies, but you're ruminating, you're not going to be as successful. You have untreated areas. Unrealistic expectations, really huge. We as therapists can't promise habituation, aka reduced distress. It tends to happen over time. As human beings, we will habituate over time, but we can't promise it because it doesn't always look the same way, and we don't know what it looks like. So sometimes it feels like this when you're waiting on that distress to decrease. So unrealistic expectations. So we help develop those realistic expectations. Big goal: change your relationship with discomfort, learning to lean in and bring it on versus escaping and avoiding. Okay. The percentage of OCD sufferers too that have another comorbid diagnosis, and I realize too, it's 12:59. Anybody who has to jump off, totally understand. I think I can do this in about 2-3 more minutes, if that's okay with the leaders. Just cut me off if it's not. So B, whoa, yes, Carla, nice. Yep, 90%. I've seen some studies that go down to like 75 or 80%, but almost everybody who comes into the office is going to have another disorder: generalized anxiety disorder, major depression, alcohol use disorder, bipolar 1, 2, et cetera, et cetera. So we also know that comorbidities make treatment harder. Well, in OCD treatment, because of these numbers, why don't we just expect it? And so we need to do really good assessment. We need to, not perfect assessment. Those with OCD oftentimes struggle with, is it really OCD? Is it something else? So a good specialist is going to help with that, and also not take too much time looking at other things. And then we make a decision of what is first order. So acuity is basically how severe and urgent something is. So if you're needing to detox from alcohol, you're not going to be very effective from exposures.